and welcome to today's webinar, Moving Forward with Meaningful Use in the Healthcare for the Homeless Setting. My name is Melissa Da Silva. I'll be acting as your moderator. This webinar is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Bureau of Primary Health Care. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. At any time, you may enter your questions for our presenters in the chat box, in the Q&A chat box, and we will attend to your questions at the end of the presentation. If you are experiencing technical difficulties, you can enter that also into the chat box, or you can call our office and speak to Molly Mindbreath at 615-226-2292, and we'll get back to you on that. So at this time, I am pleased to turn the mic over to Anna Gard. Anna is a consultant with the National Healthcare for the Homeless Council. She is our PCMH and Meaningful Use guru and has led us in the development of over a dozen products related to PCMH and Meaningful Use for the Healthcare for the Homeless community. Thank you all again for joining us, and I now turn the virtual mic over to Anna. Anna?
Good afternoon, everyone, or good morning for some of you who may be on the West Coast. Thank you so much for logging in today. I'm very excited to have two really dynamic speakers share this topic, moving forward with meaningful use in the healthcare for the homeless setting. We know that health IT, particularly electronic health records, facilitates the strategy for quality improvement. And meaningful use is the bridge between quality improvement and information technology. We can't improve what we are doing without better organized information and measuring what we are doing. So health IT is that tool that supports the ability to capture data in a structured or organized format to identify risk and improve quality of care and health outcomes. This helps us with integration and coordination of care by using tools like the electronic health record, personal health record, health information exchange, and improve quality and safety by using clinical decision support for evidence-based medicine, looking at performance measurement and improvement, and enhancing patient communication and engagement. There are special challenges that we face as healthcare for the homeless providers in using electronic health records. And so today we have from the CMS, Robert Anthony, and he currently serves as a health specialist in the Office of eHealth Standards and Services at the Center for Medicare and Medicaid Services. He contributes to policy development and implementation of the Medicare and Medicaid electronic health record incentive programs. And he will review questions related to meaningful use, Stages 1 and Stage 2, and the core requirements for attestation. Then we'll move on to Lance Lutrell, who currently works with Christ Community Health Services in Memphis, Tennessee, and is the administrator of oral health services. Over the past year, he has facilitated the adoption of the electronic health record at 6 sites, including the mobile van for the homeless, as well as successfully attested for meaningful use Stage 1 for all eligible professionals at Christ Community Health Services. So he will help share his experience in implementing and attesting to meaningful use Stage 1 in their health center. So thank you both our speakers for being here. Thank you, listeners. And I would like to, before we get started with our speakers, we're going to ask the listeners to do a very brief one-question poll. And that question is, are you an established, meaningful user of an electronic health record? Okay, so it looks like we have about 36% of those listening are, 45% are not, and 18% are partial. So thank you for taking a moment there, and I would like to hand over the mic to Robert Anthony from CMS.
Thanks, Anna. So this may seem a little bit premature for some of you, since some of you are not established users of EHRs yet, but I'm actually going to talk about Stage 2 of meaningful use. For those of you who are familiar with the Medicare and Medicaid EHR incentive programs, it is a planned 3-stage approach. We've released requirements for Stage 1, and we have now released just at the end, or I'm sorry, the beginning of September, requirements for Stage 2. Everybody does begin at Stage 1, so these won't be immediately applicable for a lot of you, but there is a lot of carryover and a lot of similarity. So I'm going to review very quickly some of the high-level parts of Stage 2 of meaningful use, and I think that Lance will probably talk a little bit more about meeting Stage 1 specifically, but I will say that on our website, which I'll give out a little bit later, you can find a very basic guide to participating in the EHR incentive programs that will also describe Stage 1 for you. In the Stage 2 rule that came out in September, even though we call it the Stage 2 rule as a shorthand, there's actually a lot more than just Stage 2. There are some retroactive changes to Stage 1. There are new clinical quality measures and new ways of reporting clinical quality measures to CMS. There are some Medicaid program changes, specifically some patient volume changes that will certainly affect a lot of people in this audience. It essentially expands it, makes patient volume calculations a little easier. And then there are some detailing of the payment adjustments and hardships that are required as part of the program that was put into place by Congress to implement these payment adjustments, but also some details about who can claim hardship exceptions. All of that is an awful lot of information to go through in about 20 minutes, so I probably can't really give you a drill down on this, but I can at least give you an overview and tell you that on our website, again, you're going to find a lot of tip sheets that'll describe this in more detail. So, again, we'll bring that up afterwards. One of the things that we often get asked is about eligibility. Currently, there is a restriction for EPs, what EPs can take part in Medicare, what EPs can take part in Medicaid. I think relevant to this particular group, we often get asked about whether we can expand the type of organizations or facilities that can receive EHR incentive payments. Unfortunately, the short answer to that is no. The decision about who was eligible for the programs was actually made for us. Congress detailed specifically who could take part, and without an actual act of Congress to change the existing high-tech law, we can't open the program up to other providers. However, we did take a look in Stage 2 at the definition of hospital-based, specifically where it refers to EPs who may practice in a hospital setting, but they may actually fund the acquisition and maintenance and use of their own certified EHR, something that is separate. A great example of this is in certain neonatal intensive care units where they have a completely different system that's completely financially independent from the hospital, and that's what the neonatal physicians use within that ward. In those cases, and in that very specific narrow case, EPs can apply through an application process to be redetermined to not be hospital-based and thus be able to take part. But other than that, we have not been able to open the program up to additional facilities at this point. The basic structure of Stage 2 stays pretty much the same. There is sort of a meaningful use path. You can maximize the amount of money that you can receive under the program if you start early. So 2011 or 2012, you maximize the amount of money that you can receive as an EP under Medicare. If you start in 2013 or 14, as you can see from this chart, there are some reduced total maximum amounts. The maximum if you start in 11 or 12 is $44,000. For the most part, none of that has changed with Stage 2. What we did change very slightly is the way that 2014 will work for everyone. And if you can see right here in 2013, we did change this. We had conceived of the program as everybody being starting in Stage 1. Think of that as the first step on the meaningful use staircase. And then once you had done 2 program years at Stage 1, 1 program year of 90 days, and then 1 program year that lasts the entire year as a reporting period, then you would move on to Step 2, or Stage 2, where you would do 2 full years before moving on to Stage 3. Because of the timing of the regulation that came out and the need for vendors to be able to develop software, we are providing a one-time extra year at Stage 1, as the arrow indicates here, for 2013 for just those folks who were early attesters, who were attesting in 2011. They will get another full year at Stage 1 requirements for their incentive payments. In 2014, even though everybody will still stay on the track with meaningful use, because we know that everybody has to update to new 2014 certified EHR technology, and because we were concerned that everyone would be updating at the same time, we wanted to avoid a funnel effect where people would not be able to onboard their EHRs and would potentially miss payments. So in 2014, and in 2014 only, everyone, regardless of stage 1 or stage 2, is going to receive a special 30-month, if you are under Medicare, 3-month reporting period instead of a full year. That will be keyed to the quarter for Medicare. If you are a Medicaid EP, then it's actually going to be 90 days anywhere in the program year. But essentially, you'll have a shortened reporting period. Again, it's for everybody in 2014, regardless of what stage you're in. And then we'll move on to 2015 with a full year for most. And that's pretty much all that this particular slide says, that the standards for certification are changing in 2014. So all participants are going to have to adopt new certified EHR technology. And then there is that reduced reporting period in 2014 as everyone adopts. There were some things that changed. For example, the way that we look at menu objectives. For those of you who aren't familiar, there is a core and menu structure to the program. There are core objectives that everyone has to meet in order to demonstrate meaningful use and receive an incentive payment. There are menu objectives, which, as you would imagine, it's a menu. You select a certain number off of that menu that you would report on, and then the others you could just wait until the next stage to do. We are changing slightly the way that menu objectives are counted. The exclusions work. There are exclusions that are provided for a number of menu objectives, and currently you could select a menu objective and then exclude yourself from it, even if there are other menu objectives on which you could report. That was intentional. We wanted to provide maximum flexibility for folks. However, we are going to close that loophole as we get further down the meaningful use path, and beginning in 2014, either in stage 1 or stage 2, you won't be able to claim an exclusion for a menu objective if there are other menu objectives on which you can report. What hasn't really changed is the way that we think of meaningful use. Meaningful use for us is the complying with an objective is complying with the measure of that objective. So you basically, if you are an e-prescriber, you need to be able to show that currently in stage 1, for example, that more than 40% of the prescriptions that you have written have been electronically transmitted. You meet that objective by exactly that, exceeding that 40% threshold. That stays true in stage 2. The other thing that hasn't really changed is that you have to hit a threshold of outpatient encounters. If you practice at multiple locations, you have to have at least 50% of your patient encounters, your outpatient encounters, at locations that have certified EHR technology in order to participate in the program. And if you are able to do that, then you can limit your denominators in meaningful use to just those locations that are equipped with certified EHR technology. So in other words, you would only have to do meaningful use in areas where you have EHR if you meet that threshold. We will provide a batch reporting option. It is not actually specific to Stage 2. We just detail it in the Stage 2 rule. It is not a group attestation in which there's a group average of numerators and denominators. It's basically a spreadsheet form that will allow you to upload all of an individual EP's attestation data in one file rather than having to go through online attestation for each individual EP as you have to do now. It should be a real time saver for practices with a large or even a small number of EPs. This is a basic use of Stage 1 to Stage 2 transformation. As you can see, and as I said before, we have a core menu structure that we used here. That core menu structure has remained intact for Stage 2, we did try to keep the total number of objectives that you have to meet relatively the same, although you can see there's been some slight difference as we move from the number of core to the number of menu and the selection number, but still a total of 20 objectives and 19 for hospitals and critical access hospitals. We did that in part by eliminating certain objectives. So you'll see that we got rid of the exchange of key clinical information objective in Stage 1, instead for an actual use case of health information exchange with the transition of care summary. We did replace some objectives with more updated objectives. So we moved from providing an electronic copy of e-health information to patients upon request to a online access of health information for all patients. We combined some objectives into other objectives, so objectives that centered around decision support for EPs, such as drug and drug allergy interaction checks were combined into a single decision support objective with actually implementing clinical decision support roles. They're sort of all of the same piece. And then some objectives were actually subsumed under other objectives. So as we move to Stage 2, we aren't asking providers to individually track how they are recording problem list, medication list, or medication allergy list. However, you're going to need to track all of those things, or you're going to need to, maintain problem lists and medication lists because you need to use them when you transmit information to the next provider of care, which you'll have to do for 50% of transitions of care. So you're going to have to maintain that information. These next few slides after this are going to center on what the individual objectives are, and I don't want to go through every individual objective because we don't really have the time for it, but I did want to focus on a couple of areas that were really crucial in the development of Stage 2. Stage 1 is really all about getting technology in place and getting people used to using it. So it was about adopting technology and then making sure that you were recording information in a structured format in that EHR. As we moved to Stage 2, we were looking to do more advanced clinical processes with the EHR and have them involved more in patient care. So we really focused on two areas that we really felt could improve the quality of patient care. One of those was patient engagement. In Stage 1, everything was centered around what the EP had to accomplish in order to meet meaningful use and receive an incentive payment. In Stage 2, we added for a couple of objectives a patient engagement piece. In other words, there are actual actions that patients must take in order for an EP to demonstrate meaningful use. So, for an example, these two that we have on the screen, one is that there's an objective for secure messaging. Certified EHRs will contain that ability to conduct secure messaging between an EP and patients, and 5% of patients must actually use that technology to send secure messages to their EP. So it's not a message from the EP to the patient, it's from the patient to the EP. We talked a little bit about providing online access to health information, which is what EPs have to do, but the corollary is that there's actually also an additional measure that more than 5% of patients have to actually go and access that information online. So we did hear a lot of comments about this, a lot of providers saying that this was going to be very difficult. How could they be responsible for patient action? But in the same way that we know that providers are in the best situation to really encourage patient compliance with treatment regimen, we think that providers are in the best position to really get patients involved with using health technology. And we've already heard some practices who are strategizing about this. The other area that we really focused on with Stage 2, and perhaps is the largest area within Stage 2, is focusing on actual use cases of information exchange. The entire idea behind EHRs is to make information exchange as easy as possible so that it can contribute to continuity of care and ultimately patient quality. So towards that end, when moving the Stage 1 menu measure of sending a summary of care record after a transition of care to the next provider of care, we moved that to the core. There is the requirement to do that for 50% of transitions of care or referrals There is also a requirement that of that 50%, 10% have to actually be electronically transmitted, however that happens to happen. And then there is finally a requirement that at least one of those electronic transmittals has to be sent to people who are using a different EHR vendor, who are outside the organization, who are, or you could potentially test with a CMS-designated test EHR if there's nobody in your area you could do that with. The idea here is not only to get people exchanging information, to get them electronically exchanging information, but to get them electronically exchanging that information outside of what we sometimes call walled gardens. So outside of your organization's network, outside of your vendor's provision or proprietary network, the ability to exchange information freely across different places of care. And that's really the goal with Stage 2. As I said, if you want to take a look at some of the individual objectives, I encourage you to take a look at our website. You can get a complete list of what all the Stage 2 objectives are. As we move into 2014, there will be a change with clinical quality measurement for this program. Currently, the way that this works is that everybody on the EP side submits either 6 or 9 quality measures to CMS. They submit them online through attestation. We really are going to move to a completely new system, electronic upload of clinical quality measures for EPs and hospitals as we move forward. And we have really tried, we've made an effort with this rule to align across programs. We know that there are EPs who are submitting quality measurement to CMS across several programs. These are just some of them. The Physician Quality Reporting System, some of you are submitting information through CHIPRA, some of you may be taking part in ACOs, and those have their own quality measurement requirements. We really were trying to get to a point where we could get to reporting once and reporting everything for CMS. Now, we may not have completely achieved that with the EHR incentive programs, but I think we've gotten pretty close. The important thing to keep in mind here is that this is going to happen for everyone beginning in 2014. So this is not a Stage 2 thing for clinical quality measure reporting. Whether you are in Stage 1 or Stage 2, this is how everybody will report clinical quality measures. As I said, we'll be beginning electronic submission. If you're in your second year or beyond as a Medicare EP, you would report your CQM data to CMS through electronic means. There are several options that are going to be open for that, including utilizing the existing PQRS system. There will be a separate attestation system, a separate electronic aggregate system that you can do it. If you are in your first year as a Medicare EP, you're going to continue to submit your CQMs through the attestation module online. You could also potentially use the batch process for that. Medicaid providers, you're going to continue submitting your CQM data to your state, and it is up to the state whether they're going to include electronic reporting. For individual information about what clinical quality measures are, because those have just been finalized, how the reporting will work, you can visit our EHR Incentive Program's website. There is a Clinical Quality Measures tab, and it will give you a little bit more of a rundown. There is also on our Stage 2 tab a tip sheet that will outline a little bit more about how clinical quality measurement is going to work. But the takeaway for everybody here is that this is how clinical quality measurement is going to work for everybody, not just people in Stage 2. There is a detail of how the payment adjustments and hardship exceptions will work for this rule. Again, Congress required that there be payment adjustments. They specifically made it a requirement that you be a meaningful user of an EHR to avoid any type of payment adjustment, which means that if you are have only received an adopt, implement, upgrade payment from Medicaid, that is not going to qualify as meaningful use. You do have to actually achieve meaningful use by meeting all of the individual measures. We have some very complicated tables that follow on the next slides, but basically it all boils down to this. We have taken a prospective approach to looking at your payment adjustment because we are mandated to begin payment adjustments for EP on day 1 of January 2015. which means we had to look at an earlier period than 2015 to see if you were a meaningful use user. And the following slides just basically detail out what those earlier periods will be. So if you are a meaningful user in 2011 and 2012, we'll look for a full year of EHR reporting in 2013 to see if you would get the 2015 penalty. If you have it, you've met meaningful use, then you won't receive that penalty. We often get asked if you have to continue to demonstrate meaningful use every single year to avoid payment penalties, and the answer is that you do. You have to be a meaningful user, which means that every year you'll have to be a meaningful user, and the rest of this just details out what that schedule looks like. If you're a meaningful user for the first time in 2013, that's okay. We just look for a 90-day period in 2013, and then we look for full years subsequently. And if 2014, the year before payment adjustments take effect, is the first time that you're a meaningful user, that's also okay. We'll just look in 2014 for a 90-day reporting period. But we do need time to process that attestation, so you have to report your attestation prior to the end of the 2014 calendar year, 3 months prior, in fact, which means you have to attest no later than October 1st of 2014. There are hardship exceptions that are set up that you can apply for. They are based on the categories of a lack of infrastructure, so not sufficient internet access, for example. If you are a brand new provider with no history of billing Medicare, we didn't want you to get hit immediately with penalties, so you do have a time-limited 2-year exception as an EP. And then finally, unforeseen circumstances, if you were to be hit by a hurricane, for example, and that made it impossible to access your records. There are also possibilities for EPs who can demonstrate that they do not have face-to-face or telemedicine interaction with patients, and they don't do follow-up with patients clinically. This is true of a number of specialists who provide consultative services. They could apply for a hardship exception. And then there are EPs who practice at multiple locations, but they lack control over whether those locations actually implement certified EHRs. You could apply under that. There is an automatic exception under the lack of face-to-face and follow-up requirement for EPs who are in anesthesiology, radiology, or pathology. If those are your primary specialties as they're listed in our provider enrollment system, then you'll automatically receive a hardship exception based on that. There are a number of Medicaid-specific changes. Essentially, we have included an expansion of encounters to those with zero-pay claims, allowed a flexibility in the look-back period for the calculation of overall patient volume. And what this means is, hopefully, that more EPs can qualify for Medicaid. That is good because the incentives are higher for the EHR incentive program through Medicaid. So if you can qualify through Medicaid, you definitely want to do that. I would encourage you, again, to visit our website. On our website, on the Stage 2 page, there are a couple of FAQs that actually will go into detail about the changes to Medicaid patient volume. This, as promised, is our Stage 2 web page link that you can go to. It'll take you directly to that. You'll find links to the Federal Register if you actually want to review the actual regulations. But more importantly, you'll find tip sheets that give you a Stage 2 overview, clinical quality measure overview, payment adjustment overview, what changes we've made from Stage 1, as I mentioned, the Medicaid patient volume calculation questions, and we're going to continue to add resources there. You can also go to our website, and if you're really new to the program and everything that I've said to you sounds like Greek, you will be able to go to our Getting Started page, download an introduction guide that'll give you a nice basic overview of the program and let you know what you need to do to participate and receive an incentive payment. So that is the end of my presentation, and I'm going to turn this over to Lance Lutrell, who will talk a little bit about how they actually implemented some of this.
Thanks so much, Robert, and found it very helpful to go through all of those details first before we tell the story of what we've done here at Christ Community. Like Robert said, my name is Lance Lutrell, and I'm here at Christ Community Health Services in Memphis, Tennessee. And prior to being here today, I was the operations analyst for Christ Community and responsible for seeing to it that all of our 45 providers attested successfully for the Meaningful Use Incentive Program. Since that time, though, I've become the Administrator of Oral Health Services here and will certainly be responsible for our attestation going forward, both on the medical and the dental side. And what I want to do here in the next few minutes is just go over what it has looked like for us at Christ Community to actually implement the electronic medical record in a meaningful way. And so we know a few of you out there still are not established meaningful users, so hopefully this will be helpful for some of you out there, and those that are, hopefully you'll identify with many of the specifics of the story that we go through here. So at Christ Community, we have 6 established medical sites, 3 dental sites, 3 pharmacies, and 1 mobile van that is dedicated to serving the homeless in the Memphis area. We have a little over 250 employees, and we saw over 90,000 medical encounters in 2011. Certainly the part that is most relevant to what we're talking about today, and certainly what is one of our greatest services that we offer, is our service to the homeless population. We have a mobile van that visits 2 different sites throughout the week, dedicated nurse practitioner and social working staff that is committed to serving the homeless population. And we've implemented the electronic medical record at this site as well, and we're glad to continue the service that we have for our homeless population. We served in the last year just over 1,400 homeless patients through this van, and we're looking forward in the next year or so to hopefully upgrading this van and then utilizing the current van that we have for our mobile dental operations. But let me jump into it here. And one of the things that I think is so important for those of us who are administrative types and for those of us who are responsible for ensuring that our employees and our staff are meeting certain federal regulations or meeting the specific requirements of the Meaningful Use Program that require significant change to workflows, or at least a mindfulness, is that you kind of have to start with, or at least the way I frame it for our staff, is that there are 3 concentric circles. And the traditional way is starting from the outside in, but I really believe the better way is starting from the inside out. And those 3 circles are the why, the how, and the what. Most of us start with the what. We tell everybody what they have to do. We tell them how they have to do it. And then we leave our people usually asking, well, why is that even important? And so what I find is much more productive is to start the other way around, to present the why. Why are we doing this? Why are we implementing an electronic medical record? And why are we attempting to attest to the Meaningful Use Program? Then we'll talk about the how, and then we'll talk about the what. But establishing that why as the core has been one of the most valuable things that we've done as a staff as we've sought to begin and continue along this meaningful journey. And so I have 3 basic reasons why that I think it's important for everyone here to identify with as they think and consider the Stage 1 and Stage 2 requirements for meaningful use. And the first one is just a picture here of Hippocrates. So every one of us in the medical world should know, at least, what the Hippocratic Oath is, and I think that there's a few points from the Hippocratic Oath that I think are certainly applicable to implementing medical records and seeing to it that they are used in a meaningful way. The biggest idea from the Hippocratic Oath is certainly that we do no harm, and by maintaining current problem lists, by maintaining medication lists and allergy lists, and having a system that can do drug-to-drug checks and drug-to-allergy checks for us, we certainly just decrease our innate ability to do harm, which is certainly fitting with the Hippocratic Oath. One of the other big ideas from the Hippocratic Oath is that we freely share information and even hard-earned insights with our colleagues, and that's certainly the goal and the target of meaningful use, as Robert was sharing with us, is that we're not just interested in keeping information to ourselves about our patients and those we're seeking to serve, but that we really do open up the walls and open up the barriers, that we're able to share the insights that we've had from being with this patient over the course of years with the next person that we're sending them to. The other two big ideas from the Hippocratic Oath that I think do motivate why we would even attempt to use an electronic medical record in a meaningful way is that we really do believe that prevention is greater than a cure. And what we need, it's certainly in Memphis, and what we need, I would think, in other places across the country are people who are much more able and focused on preventing diseases rather than simply curing them. And what we have found, we've just begun to tap into, is the ability of using our EMR for population management and being able to create panels of patients with a certain diagnosis and manage them proactively and preemptively rather than waiting for them to come back through our doors. And that's certainly applicable for us in our very transient homeless population, is being able to monitor them and keep a track of them even when they're not coming back in a regular way. And then the last part of that is certainly navigating between overtreatment, the narrow road between overtreatment and neglect of treatment. And, again, being able to use electronic medical record in that way is a motivation for heading down this path. The second kind of major motivation, I think, is in line with what's here at the National Healthcare for the Homeless Council, is even in the mission here. And the big ticket items there would be that, the NHCHC is really striving for advocacy for the improvement of healthcare systems, and without implementing technology to that end, I don't see us being able to accomplish that. And so I certainly see that meaningful use is one of those stepping stones to be able to improve the healthcare system at large. The second one, as we touched on earlier, the ability to manage a whole panel of patients instead of burying critical information in paper charts on shelves. We really are able to research this information much more rapidly and much more easily than we could in the past as we've adopted our EHR and begin to test for meaningful use. And then the third thing here that's fitting with this council is that we're really organizing healthcare providers to provide better healthcare for the homeless. And that's what Anna mentioned at the very beginning of today's session, is that we really are striving to advocate for these measures and these incentive programs in order to organize providers in a meaningful way. The last thing for us is what motivates us as Christ Community Health Services, and really what I would encourage everybody to do is as they seek to implement these changes with their providers and with their staff, is to really connect these motivations and these requirements with what the mission is of your organization. It's very simple. We should always do that, but it's worth saying again. And I just want to share for the moment how we've done that. In our mission statement, the core part of it is that we are here to provide high-quality health care in the context of distinctively Christian service. And so it's so important for us to focus on the idea of high quality. And the idea here is that we fight, being a federally qualified health center, we constantly fight the battle of making quality our objective and cost our constraint, instead of making profit our objective and sort of quality our constraint. But what we've been able to do is that our quality improvement committee has been able to, hone in on our hypertensive patients and see how they're doing over time, and being able to chart out our diabetic patients and how many have an HbA1c in an acceptable level, so that we can ensure that we are aiming for and that we are targeting high quality. The other two interesting pieces I think I would at least mention in the why we're targeting this is that for us, in light of the distinctively Christian service, it's just so interesting in an application to this council is that Jesus is quoted as having said that foxes have holes and birds have nests, but the Son of Man has no place to lay his head. And so we certainly see our mission is providing this high-quality health care, not just to anyone, but to the people that were like Jesus without a home. And we see our service to the homeless population as being very much a response to the faith-based initiative that we are. And then the last one, which is worth speaking to, because we have a tendency to often see regulation and incentive programs as just sort of federally mandated requirements that we have to meet, or else, or we're going to get the stick instead of the carrot. And I think that it's important for us to note in our organization that we really do see our Christian service compelling us to comply with and to excel at the government regulations that are put in front of us. And so, again, I understand we're speaking to a diverse crowd here, but I just want to mention that it's worth saying that as you begin to tackle something as significant as implementing an electronic medical record, it's worth thinking through how that ties in and how that really informs the mission that you are trying to accomplish as an organization. So now let me dive in quickly here to the how and the what of how that looked like at Christ Community. And again, I'm intending this much more along the lines of a story format, sort of put flesh on the bones of the core requirements that have been put forth. For us, implementing the EHR really does, the how kind of falls into these narrow paths between three major tensions. And the first of those is providing something that is user-friendly to the provider, something that is easy for them to use and doesn't provide obstacles in their providing care to our patients, but then something that's also helpful on our practice management side. A second major topic here that we'll go into each one of these here in just a moment a little more in depth. The second major thing is that really trying to navigate this idea of costly abstraction, and what I mean by that is taking our paper charts and turning that into structured data, and then cutting access to information, because there's this very delicate tension between using providers to abstract the data and be able to verify it, and then sort of saying, okay, we have what we need, and we'll go ahead and archive the rest of this. And the last thing here that's I think of particular use to anyone in this field tackling is worth thinking through how much of this are we actually going to mimic the paper workflows that we've had versus adjusting for meaningful use workflows, and how much are we willing to leave behind and sort of to not just use the EMR as an electronic paper flow, but actually taking and utilizing the things that the electronic workflow can actually offer us. So I'm going to tackle these briefly here on the following slides. The first one for us was, actually choosing a vendor that our providers found to be helpful and useful, and that ended up being EMDs for its just charting ease, and we actually used that on tablets. But and it works for the most part for our back end. What is helpful for the meaningful use standard is that our vendor was very good on the front end of developing the reports that we would need to be able to attest for meaningful use. And that was largely in part to the fact that our charting system and our practice management system were actually integrated here in one system, and that allows for us to be able to determine the denominators for many of our core measurements from the practice management side, and then use the numerators from the clinical side here. The second thing that we kind of talked about was, and it's worth considering. It certainly has a cost with it, but for us, as we begin to adopt our electronic medical record and certainly begin to put in place the meaningful use requirements, we actually reduced our provider productivity on a percentage basis across the board, and begin to up that as the months went on. And largely this was in order to give providers the time that they needed to be able to turn the information in the paper charts into structured data. Certainly some of it was the learning curve, but much more of it was the data abstraction process that we had to account for. And then the third thing we mentioned here is actually making the transition and adjusting the workflows. And the way we tackled that and the way we did that is that we brought our providers and our entire staff into one location. We brought them to our central location for 2 days to sit them down and talk through what the new workflows would look like, how does the EMR work. Then we send them back to their clinics for 2 days to have kind of on-hand support. But, the biggest thing that I found, even in our most recent implementations, has been actually a needed focus on the support staff much more than the providers. Even though the providers are ultimately responsible for the execution of the patient visit, I found that being able to support and inform and train our nursing staff and our clerical staff has been one of our greatest sort of accomplishments in being able to do this well. And one of the ways that we've done that is identifying what we call a super user for each one of the areas in our clinics, and being able to really go to that person, and that being the on-site expert, so to speak, for the EMR and for anything that's relevant to the Meaningful Use Incentive Program. One of the other things we've done is that we've taken just fake patient walkthroughs. We've taken people, the staff, and just sort of handed them a generic visit note and just had them walk through and sort of act the part so that we can see that everything in the workflow is happening as it should during that training week. And then the last couple of things here is that we certainly seek to engage the entire clinical staff for the EMR transition and to achieve meaningful use. It's just so important that you identify the things that in your practice you really can relegate out of the provider's hands so that you can continue to emphasize for the provider their care to the patient. I'll mention those things that for us we've been able to delegate out. The last thing here is that we've been able to work through and with an organization called QSource. There are 10 rec program that they've been for us the experts on how to go about achieving meaningful use and be able to actually change our workflows in ways that are helpful to us and also help us meet the requirements. So finally, we've kind of covered the why and the how, and then I'm just going to hit the what here. We've worked really hard to educate and inform our providers about it, and I'll have an individual slide for each of these points here. We've used and created reports to establish provider accountability to our meaningful use requirements, and then we've also worked to find some workarounds with our particular vendor to be able to accomplish these workflows that are helpful for us. One of the things is, like Robert mentioned, finding these quick tips or quick guides are super helpful for our providers to be able to see kind of all the core requirements at a glance, and so what we did is that we took our EMR and actually broke down each one of the core requirements for stage 1 and the menu sets that we were going to attest to, and took screenshots in the EMR for where a provider would find the button they needed to click or the box they needed to check in order to satisfy those requirements. And that's been of a great help. For us, that quick guide was just front and back of a landscape standard 8.5 by 11 letterhead, and just gave that to our providers to be able to see, when we're giving that feedback, where would they be able to find it and how would they be able to correct if they were missing any of the marks. The second major piece that we've done, of course, is having the meaningful accountability, is being able to put back in front of providers, and in a lot of cases even being able to compare other providers in their own setting of how they're measuring up on these standards. And as you can see, for us, just being able to see that in a dashboard format where we are actually seeing all the standards at one time. And what's encouraging to our providers for the most part is being able to show and illustrate to them that that the EMR really is set up to accomplish most of these tasks without them thinking about it, that the workflow really is set up for them in such a way that they'll accomplish most of these core requirements without even thinking about it. And we'll address the few that we've tackled that didn't fit into that standard pattern. The last thing here is, as far as decisions that needed to be made, was which menu set items do you actually go ahead and tackle? And for us, the guiding rule of thumb was to be able to make meaningful use as close to how the providers were already using the system as possible. And so for us, that was including lab as structured data, getting that back from LabCorp and Quest automatically through an interface that was developed. The second one was being able to generate a patient list, and for us that was being able to generate lists for our HIV-positive patients, and we can do that centrally, so that takes the burden off of the providers. The two that are highlighted here we used interchangeably depending on which ones the providers were able to do. One was sending clinical reminders to patients to come back in for specific diagnoses. On the other hand, the other one that we've used is having providers actually print patient-specific education. And the difficulty there, or the opportunity, I guess, to reframe it, is that it actually requires the provider to do something that was maybe not what they had done before. So we've had a little bit of difficulty on that one, and so in some cases have gone with the clinical reminders instead. And then the other two, menu set 8, the transition of care document, our front desk was responsible for that. And then, as Robert mentioned, on the immunization data submitted to the state, we've actually used that in the exclusion. So there's an exclusion if your EMR vendor actually charges you to develop the submission of the immunization data, and so that's how we attested for that menu set item, which is actually one of the required for eligible professionals, I believe. So lastly here, some of the obstacles that we've tackled specifically in the context of our mobile van for our homeless has been the generation of visit summaries. And that's been one of the difficulties because it requires the providers to be reasonably finished with their note at the time the patient departs. And so that requires kind of a new way of using the charting system instead of catching up later. Because the requirement's at 50%, it requires for us to pitch it to our providers as sort of doing for every patient if they can, so that they'll be certain to hit that mark. Some providers say that it feels like a waste of paper to them because they're not always handing it to the patient or the patient's throwing it away on their way out. But the main motivation that we've been able to sort of reframe this for our providers and our staff is to demonstrate that certainly for our homeless population, it gives them at least a medication list that they can go to the pharmacy where we've sent their medication and be able to know whether they've gotten all their medications or not. The second thing is for our transient population, our homeless population, it gives them the documents that they'll need if they ever come back in or if they present at another location. Let's go on to the next slide here and just mention the last thing that was really a unique problem for our mobile van, and it was the e-prescribing list, the quota for meeting the e-prescribing. And the issue here is that we had our mobile van was actually providing many sample drugs to our patient, but was documenting it in such a way that it looked like they were writing a prescription and then filling that with the sample drugs. And so that was decreasing the percentage that were being counted as being e-prescribed. And so what we did, we found a way in order to accurately document them as sample drugs and not as true prescriptions, and therefore be able to document the correct e-prescribing amount. And so then just in conclusion, as a reminder, I would just encourage everyone out there as they begin to tackle these meaningful use, there's certainly a lot of documentation you need to work through, but the important thing I think that as you go back to your own practices and you go back to your own organizations to present this transition is that you've been focusing on the what the whole time, but that as you present it to people for the first time that you really do start with the why. Why is this important? Why is this helpful to our organization? Why is this going to enable us to provide the highest quality care that we desire to give to our patients instead of viewing it as something that you have to do and then leaving people with wondering why. So we'll end there, and again, I appreciate being here this afternoon, and I'll turn it over to Melissa from here.
Thank you so much, Rob Anthony of CMS and Lance Lutrell from Christ Community Health Services. That was a terrific, dense presentation on meaningful use. I believe we have a couple of questions, so I'm going to turn the virtual mic over to Anna to moderate some questions from our participants. Anna?
Okay, so we have a question about the issue of behavioral health providers. Where does the sharing of behavioral health information stand in terms of meaningful use? As we know, behavioral health challenges are prevalent among the homeless, so it's important for providers who work with the homeless. If we can actually give this to Robert, if he wants to address with meaningful use how eligible providers deal with if behavioral health providers are eligible providers, and if not, how to tackle this.
Sure. I think there are two issues. Well, there's probably several issues at play here, but the two that pop out at mine are exactly as you say. One is the question of what behavioral health providers are actually eligible, and the second being what information is really there. So in regards to the first, the only behavioral health specialists that really are going to be involved are folks that have a medical degree. There are certainly those out there, but when it came down to it, a number of the other behavioral counselors, certainly different type of mental health facilities are not on the list that Congress established as being eligible for the incentives. That said, I know especially for this population that is a concern. There are people who are putting information into a health record. There is not an issue with doing that and providing that. Certainly as we start to see in Stage 2 more of the transition of care information being sent to the next provider of care, I think that's going to be an important part of care coordination. But most of the recording objectives do at this point in time focus on very high-level recording, so a problem list, a medication list, vital signs, those type of things. There will be in Stage 2 a menu selection that most EHRs actually incorporate the ability to do already with electronic notes that do provide the ability to feed that information. To the second point, too, I think that the reverse also comes up, is there's a real concern about what information is actually made available within an electronic record and to whom that is made available. So this is especially something that comes up in regards to behavioral health. I know that there are certain situations when we would not always want that information to follow the patient to the next provider of care. That is not a requirement to enter at this point in time, and even when it is something that may necessarily be on a problem list, we do provide within the regulations the ability of the referring physician to really make a judgment as to what information may be potentially hazardous to a patient or potentially dangerous to reveal through those means, and the provider could withhold that information if they thought that there was a particular danger to it. So it cuts a little bit both ways, I think, when you look at behavioral health.
Okay, I have a few other questions, and actually Lance did a beautiful job addressing one of the issues that are potential barriers to the healthcare for the homeless population and the workaround that they created in terms of the electronic prescribing when they have on the mobile van for the samples. As you, Robert, went over Stage 2, the increased focus on patient engagement with greater than 50% of patients sending secure messages to an eligible provider and 5% patients must access information online. Clearly that is a big barrier for our homeless population, as many don't have access at all to computers or internet. Has that been considered in the development of the meaningful use Stage 2, and would that be considered an exception? I do know you listed broadband exclusion, but access is a real issue here for our particular population.
Sure, we definitely did get feedback about that from a number of different groups in the public comment period. At this point in time, there is not an exception for the patient population. There is just an exception for broadband access. I can tell you that a number of folks are already beginning to strategize about how to tackle some of that issue. I do know for this crowd that is a much higher lift than for some others. But I know that a lot of people are actually using or talking about using those patient portals as what, for lack of a better term, we would call a teachable moment or an education moment, where they are actually sitting down with the patient at the point of care with that online portal, helping people access that online portal to review their health information on the spot and to review patient education on the spot so that they can meet that 5% requirement.
So it sounds to me then it would be incumbent upon the health center either to have a computer portal kiosk in their waiting room with a patient portal availability in order to meet that. I mean, they need to provide internet access and the computer access in order for them to meet this provision. So it becomes an added responsibility, I suppose, for HCH providers and health centers who serve such population.
Yeah, I don't know that it's necessarily incumbent, and I know that there are folks who are serving underserved populations that are not necessarily confined just to one group. They're providing services to homeless populations in addition to other populations, and are certainly hoping that or looking to meet their 5% patient engagement with different populations, obviously, than those who don't have access. If that's not possible, like I said, this is certainly one option that I know that other practices are looking at.
Okay. We certainly have pretty much wrapped up our time. I do want to ask quickly, Lance, if Christ Community Health Services is moving towards patient-centered medical home recognition, since Meaningful Use Stage 1 gets you 50% of the way to patient-centered medical home. Can you let us know where you are with that?
Thanks, Amy. Yeah, we're certainly looking into that. We have one of our locations is actually a family medicine residency site, and so by the stipulations we have for that residency program, we will have to demonstrate that we are a patient-centered medical home. And so we're looking and hopeful that in the course of the next year that we'll actually be able to achieve the patient-centered medical home status for one of our locations, and then hopefully use that as a model that we can then replicate it at each of our subsequent sites.
Wonderful. Well, thank you both so much for your time. Thank you for our participants. I think we have used up all of our time. We do have a resource slide here at the end, and I think I need to hand the mic over to Melissa for a quick wrap-up.
Oh, thank you so much, Rob Anthony of CMS, and thank you so much, Lance Lutrell from Christ Community in Memphis, Tennessee. And I want to just alert the audience that this webinar will be archived on our website at www.nhchc.org within 3 business days. I want to do a special thanks to our consultant on all things PCMH and meaningful use, Ms. Anna Gard. Anna is available through the Council to provide technical assistance and training on both of these topics. And I am so impressed that this webinar on meaningful use has taken us from those early conversations, very general conversations 2 years ago, to a place where we were talking about stage 2 and stage 3 and 50% of the way to PCMH. So this is all very exciting. Do check out our website. Again, we have several other webinars archived with case studies from other HCH grantees who are in the process or who have achieved PCMH and have become meaningful users of electronic health records. We have another webinar coming up next week with Anna Gard and a couple of other HCH grantees on patient-centered medical home, and we will have several workshops, trainings at our national conference in March in D.C. and our regional trainings next year, May, in New Jersey. So please check out our website and give us a call if you've got questions. Shoot us an email. And please take our survey as you exit the room so that we can improve our content and delivery on this and other topics. Thank you all so much, and have a terrific rest of the day.